Okay, so we are going to do a brief introduction to HIV pre-exposure prophylaxis, what we call HIV PrEP. The subject was an audience request. Although we've been using HIV PrEP for quite some time, there's always room for opportunity to continue to create more awareness. I have no conflicts to declare, and I might mention some trade brand names, but this does not represent any affiliation of pharmaceutical companies with the U.S. government or the Department of Health and Human Services. And please note that I might only use the trade names for educational purposes only. The learning objectives are to briefly describe HIV epidemiology in the U.S. and why pre-exposure prophylaxis is an essential tool to end the HIV epidemic, list strategies to reduce HIV transmission, describe the currently approved medications for HIV PrEP, indications, contraindications, and efficacy. So I'm going to start with the PrEP with a case presentation. I don't think I have access to the chat right now, but you guys can comment the answer in the chat, and then perhaps someone can tell me what the answers are. So this is a 28-year-old man who has sex with men who has a history of prior sexually transmitted infections for this year. And the question is this patient at risk of HIV infection? And what HIV prevention strategies would you discuss with your patients or clients? So specifically, which of the following is the one that's most likely to further reduce these patients' risk of acquiring HIV? We have abstinence education, circumcision, increased condom use, monogamy, or PrEP. Oh, I can't see the chat. I'll wait for your answers. And then, great, so we have a couple of E's. Because this is a PrEP talk, it must be a PrEP answer. And the reality is that all of this in theory, in conjunction, is associated with reduction of HIV, of risk of acquiring HIV. But some of them have a lot more scientific basics, evidence-based strategies that have been proven to reduce the risk. So abstinence education and increased condom use is directly related to behaviors. And then we know that changing behaviors in patient populations can be really difficult sometimes. Circumcision can reduce the risk of acquisition of HIV. Data is not very extensive about this, and it might not be widely accepted for many patients. Again, monogamy is a behavioral choice, and then might not be feasible for certain patients. And then so definitely PrEP is the most likely strategy from this list to reduce this patient's risk of acquiring HIV in their lifetime. And then so when you look at the epidemiological data of HIV in America over time, many of you have heard that the lifetime risk of HIV in the US is primarily identified or primarily clustered in the southern states. This map is really impressive. When I first saw it, I had to double check and see that the numbers were right. This was published in 2015 from CDC, and then according to the data that they had, 1 in 81 people living in Texas will be diagnosed with HIV sometime during their lifetime. This is incredible, and it's kind of scary too. And then so these are areas of opportunities for us to extend strategies that can reduce that risk and can change these numbers over time. This is 2015 data, but it's still prevalent. When we look at HIV in the US in general, we know that about 1.2 million people are living with HIV currently based on the most updated CDC numbers. And then so this is actually about 13% of the general US population. It's something that is prevalent. But unfortunately, 1 in 7 of these patients don't know that they're living with HIV. And this is one of the reasons why it's so hard to end the HIV epidemic in America. The risk of transmission of HIV in someone who does not, from someone who does not know that they're infected is much higher because the viral load is higher, and they might not know to reduce the risk behavior that they have been practicing previously. And we're still seeing a lot of disparities in terms of HIV care and prevention in the United States, and this is what drives the epidemic in America. 2 out of every 5 patients newly diagnosed with HIV are youth. African American MSM have 5 times the national average of new HIV diagnosis compared to the rest of the population. 1 of every 2 women infected with HIV is African American. So we see disproportionate, this population is disproportionately affected by race. And from 2010 to 2014, diagnosis among all Hispanic Latino MSM increased 13% among young Hispanic Latino MSM. And so the specific population, Hispanic Latino MSM, they are also disproportionately affected by HIV. But there's been improvement over time. So then this slide is a little bit old. Fortunately, when you trend HIV diagnosis, and we were seeing it here already in 2015, just a decrease of new diagnoses per year. And this is still being seen in the latest data from CDC, just lower amounts of diagnosis per year, which is great, but it's still not yet to the goal that we had defined when the HIV epidemic initiative was defined in 2018. So there's still room for improvement. What else can we do to reduce acquisition of HIV and reduce new transmissions? So increase testing and linkage to care. This is something that's really important because, as you know, 1 in every 7 people living with HIV don't know their status. And normalizing testing is going to be key to make sure that we reach those patients who may not feel confident releasing or disclosing to their providers what their risk factors are. Delayed or fewer partners, that again is not necessarily something that's feasible for many patients. Participate in less risky activities, increase condom use. Yes, that's part of some of the tools that we have, but again, it's not realistic for a big proportion of the patients that are affected by HIV. Empowerment and negotiation skills, allowing these patients to understand that there's tools to reduce their risks, and then asking their providers for access to these tools. Reducing alcohol and drug use, because if they don't use drugs, they're less likely to participate in risky sex or risky behaviors. Reduce psychosocial barriers, access to HIV PEP and PrEP, STI treatment, because STIs can cause inflammation of the mucosa, and that is more vulnerable to acquiring HIV if they participate in sex. And circumcision again. And then this is just a reminder that historically there were lots of restrictions about when you could do a test for HIV for someone. Historically, the requirements were to make sure that patients had signed the consent for this, and that you had given the patient education about what to do with the results if the results were positive. And so what this showed is that it just added barriers for people to ask to get tested or people to offer the test. So in 2016, CDC created more awareness, and they updated their guidelines and said everyone should be tested for HIV, no matter what is the risk that they're reporting. So test all patients 13 to 64 years old. In the United States Preventive Task Force followed, and their age range is a little bit different, but pretty similar. And just kind of making sure that we're normalizing offering HIV tests to everyone. And that's how I tell my patients. Now it's recommended that everybody gets tested for HIV, and they will just accept it. And then you will test it at least once in their lifetime. But if the risk persists over time, you can test it more often than that. And then you want to test all pregnant women, all patients with tuberculosis or sexually transmitted infection, and you want to test high-risk patients at least annually. We do it more often for those taking HIV PrEP. But unfortunately, the screen that is currently being done is still not sufficient. At least 38% of new HIV diagnoses in the US are diagnosed with advanced HIV disease. What that means is that these are people that have lived with HIV for at least 7 to 10 years. Sorry, apologize. So that there's a big gap of a missed opportunity where we could have diagnosed this patient earlier. And the earlier we diagnose them, the earlier we can start treatment, suppress their viral load, they have better outcomes, and less likely to transmit it to others. People who know they're infected, they can start treatment, they can be linked to resources. We know that in the US, people living with HIV can get access to treatment still nowadays, even if they don't have insurance. And HIV treatment results in viral suppression, reducing transmissions. So this is the concept of U equals U, undetectable is untransmittable. If the virus is suppressed, it cannot be transmitted sexually. And this is very important. One of the key features that I discuss in all of my patients that are newly diagnosed is that if your virus is suppressed, you will not be able to transmit it to your loved ones. And this is very empowering for them. The transmission risk, of course, is different based on the practices, the sexual practices, or the potential exposure. We can see that the transmission risk can be as high as 0.3% for blood transfusions or blood exposure, blood transfusion specifically. But receptive anal intercourse can be as high as 3% per episode. So I still have patients who tell me, like, how is it that my wife doesn't have HIV? And I explain to them that receptive vaginal intercourse, the risk per episode of acquiring HIV is 0.1 to 0.2%. So it depends on how frequently you were having sex. The reality is that the risk is much lower compared to receptive anal intercourse. And some of these other practices. So I like to show patients this slide. Oftentimes patients come after having participated in oral sex and to discuss whether they need to take anything to reduce the risk of transmission of HIV. So I present them with this slide, and the likelihood of transmission through receptive oral is quite low. So that brings us back to the definition of PEP versus PrEP. So PEP is post-exposure prophylaxis. It is a combination of antiretrovirals that is given after the high-risk exposure has occurred, and we want to start this within 72 hours of the exposure for it to be effective. When we do recommend PEP, we recommend a 28-day course of a daily antiretroviral therapy, which is a 3-drug regimen. That's a complete antiretroviral therapy combination. And just a caveat that this is different than doxy-PEP. Doxy-PEP is taking doxycycline after high-risk exposure to reduce the risk of transmission of syphilis and chlamydia. So this is specifically for HIV PEP. And then, so how is it different to HIV PrEP? So PrEP is pre-exposure prophylaxis. It's daily antiretrovirals taken before the exposure to reduce the risk of HIV infection. You want to start at least 7 days prior to the exposure, and it's a daily 2-drug regimen, which I'll explain in just a second. So these are the tools that we have currently FDA approved for HIV pre-exposure prophylaxis. We have 2 oral formulations. These are antiretrovirals that have been in the market for treatment of HIV for a very long time. The first one that came out to the market is called tenofovir disoproxil and emtricitabine, and that's brand name Truvada. And then, so over time, Truvada has been associated with risk of developing certain renal issues and potentially issues with bone mineral density or osteoporosis. and therefore the pharmaceutical company developed a newer formulation called Descovy. Descovy is a combination of tenofovir lafenamide and emtricitabine. They have both been studied for PrEP. Truvada has been studied for PrEP on people who inject drugs, men who have sex with men, cisgender women, and it's in transgender women and transgender populations. So Truvada is approved for that population. We'll talk about the contraindications in just a second. Descovy was studied for PrEP compared to Truvada, specifically in men who have sex with men and transgender women. So it is not approved for pre-exposure prophylaxis for cisgender women, unfortunately, because that population was not included in the trial that got the FDA approval for Descovy for PrEP. They both should be taken one tablet by mouth every day. We typically, the recommendation for guidelines is that we only prescribe a 3-month supply because these patients must come to the clinic every 3 months to get tests for HIV and other STIs to make sure that they haven't acquired the infection, because this combination alone is not sufficient for treatment. It's great for prevention. We'll talk about efficacy in just a second, but not sufficient for treatment. It's approved for adults and adolescents who weigh more than 35 kilos. And there are 2 injectable FDA-approved formulations for pre-exposure prophylaxis for HIV. The very first injectable that was approved for this purpose is called cabotegravir. This is an integrase inhibitor, so it's a different class than the oral PrEP. The oral PrEP is a nucleoside reverse transcriptase inhibitor, and this is an integrase inhibitor. It's actually a really potent medication that lingers in your bloodstream for a very long time. It's 1 deep intramuscular injection every 2 months, and it was actually compared to Truvada. It was found to be superior in terms of reducing the risk of transmission of HIV. They do need labs more often, so they don't need to remember to take the pill every day, but they need to come to the clinic every 2 months for their shot. And before they get the shot, they need to have labs drawn. And that might be a little bit difficult for some patients to come to the clinic and get labs drawn every 2 months. So it might represent more frequent visits, more laboratories that sometimes the insurance might not cover. So it's something that we kind of want to take in mind, to keep in mind when we're considering cabotegravir for PrEP. It's approved for adolescents and adults adults and adolescents who weigh more than 35 kilos, and for cisgender women. And it does not impact renal function, so people who have renal disease can still get apretude for PrEP or cabotegravir. And then again, it's a deep intramuscular shot, so they have to come to the clinic for it. It's not recommended for patients to self-administer at home. And then the latest tool that was approved by FDA for prevention of HIV is called lenacapavir. The brand name is Yeztugo. This is a completely new class of antiretrovirals called a capsid inhibitor. It just kind of distorts the quality of this package where the HIV is kind of contained within the virus, and that interferes with the capacity of the virus to replicate in multiple different steps. So the really cool thing about lenacapavir is that it's a subcutaneous injection every 6 months. So this is really amazing. They only have to come for that shot every 6 months. Ideally, they should come to the clinic for STI testing every 3 months regardless, but for the injection specifically, it's every 6 months. It's not supposed to be self-administered, so patients still have to come to the clinic for the injection. And there are the biggest potential side effect besides pain, which is not terrible, but it's actually that they can develop these skin nodules that can persist over time for several months after the injection. So some patients may or may not be okay with that risk. But this was approved for people at risk of HIV via sex acquisition for adults and adolescents weighing at least 35 kilos, and this includes cisgender women because they were included in that trial that led to the approval. So like anything, there's advantages and disadvantages of using the injectables versus oral PrEP, specifically for the long-acting cabotegravir. So there's the advantages is that there's demonstrated superiority in clinical trials. It doesn't require daily dosing. It might be a more discreet option because they don't have to take their pills with them where they go. And then for some patients, if they have kidney disease, they might not have good options in terms of PrEP. So people who have competing priorities that might interfere with their adherence challenges, homelessness, intravenous drug use, it might just be easier for them to just come every 2 months for their shots. But it is more frequent encounters. It may or may not be covered by their insurance because of cost. They do need laboratories every 2 months, otherwise the shot shouldn't be given. And breakthrough infection can still happen despite on-time injections, and it can actually be harder to diagnose because when you're on these medications, you actually suppress the virus compared to like if you were taking anything. So the development of an antibody and a viral load takes longer. And resistance to this important class of antiretrovirals can develop if they have a breakthrough infection, which might make it harder for us to treat HIV if they acquire it. The indications for HIV PrEP, when you look at CDC, the indications that they give you are really, if a patient is asking for PrEP, then that's an indication. But if you want more specific criteria, then men who have sex with men, if they have a partner who's living with HIV, and you can take into consideration that if the partner is taking the medications consistently and they're virologically suppressed, they might not need to, but you can still prescribe it for additional peace of mind, and that's okay per CDC recommendations. Having had an STI, inconsistent or no use, you can make an argument for HIV PrEP for heterosexual women and men too, based on the above criteria. And then for people who inject drugs, I just want to remind you that the only tool that has been studied to reduce HIV acquisition for people who inject drugs is Truvada. But if they share injection equipment, if they have a positive partner that they're sharing equipment with, you can make an argument to offer HIV PrEP for this population. Contraindications, so if they have active infection, because PrEP is not sufficient for the treatment, it's sufficient for prevention, but not for treatment. Renal dysfunction, we cannot use certain medications if they have an allergy to these components. And then you want to use it with caution in people with hepatitis B, as tenofovir actually is an antiviral that will suppress tenofovir. So if they discontinue it, all of a sudden that can lead to hepatitis flare. This is a very effective tool. I'm going to go a little bit fast in the interest of time, but multiple studies have demonstrated that HIV can be as effective as 92% if taken consistently. When you see the efficacy actually decreases based on the detected levels in blood samples. Part of the reason why when you look at the injectables, the studies that led to the approval of the injectables, they actually check levels of oral tenofovir, and they identified that the superiority likely is driven by lack of adherence to the oral PrEP. You can make an argument for HIV PrEP in pregnancy if someone meets high risk for HIV acquisition. It's not contraindicated. It's category B. It's a medication we use for treatment of HIV all the time in pregnant women with very safe safety data that is very reassuring. And then, you know, it's still important to weigh in your risk versus benefits and having conversations with the patient. And then fortunately, we're seeing that PrEP access is improving. The latest data that I saw from CDC shows that at least 32% of patients who would benefit from PrEP now have access to it nationally. And this might be different in different locations. So we want to make sure that the goal to end the HIV epidemic is actually to make sure that at least 50% of people who benefit from HIV PrEP should be given access to this tool. So fortunately, there's more and more awareness, more people asking for PrEP. We still have lots of room for opportunity to expand access to these evidence-based life-saving tool. So in summary, there's 4 available FDA-approved antiretrovirals that prevent HIV infections. This is an effective evidence-based tool to reduce the risk of transmission of HIV, but adherence is key. It's not a perfect tool, and we need to make sure we're increasing access and normalizing access to PrEP in our communities. And these are our references. I'm going to stop sharing now and allow for questions.